bacterial ribosomes, 70S ribosomes, very different from eukaryotic ones. It's not about numbers, they're structurally different. Which means if we find the way to inhibit the activity of the ribosome, interfere with its structure, for example, okay, bless you, specifically for bacteria, we will be able to selectively inhibit the growth of bacterial cells without ideally affecting the growth of eukaryotic. Turns out that the drugs that target bacterial ribosome have very high specificity, high specific toxicity, and in terms of the side effects, the level is acceptable. They aren't without side effects, but they're not horribly bad, right? All those drugs are either natural, like aminoglycosides coming from streptomyces and actinomyces, or semi-synthetic, derived as modifications of those original drugs. So drugs like gentamicin or kanamycin, also belonging to aminoglycosides, were derived from the original formulations of streptomycin, kanamycin, streptomycin, actinomycin, neomycin, by chemical modifications. That makes sense? The only class that is synthetic is oxazolidinone. So linezolid, the effective drug that is used to treat mycobacterial infections, okay, was entirely synthetic. What can you do to the ribosome? Aminoglycosides and tetracyclines bind to the 30S subunit. Aminoglycosides change the structure of the 30S subunit, changing actually the structure and the function of the proteins that are produced, essentially rendering them dysfunctional. Okay? Tetracyclines prevent binding of transport RNA to the 30S subunit, and when transport RNA cannot bind, there is no synthesis. 50S inhibitors include chloramphenicol, macrolides and lincosamides, and those drugs in different manners inhibit actual elongation of the protein, actual synthesis. On this slide and in some others, I took the side effects in the black boxes with white letters. So you can see that they have some side effects, like chloramphenicol in the long-term perspective can cause aplastic anemia, which is really hard to treat. So it is pretty much toxic for bone marrow. Aminoglycosides, considerably toxic for kidneys, CNS, and also may cause different abnormalities with hearing, starting from tinnitus and ending with the hearing loss. The most famous side effect of tetracycline treatment, drugs like tetracycline or doxycycline, is phototoxicity, which means that the patient on heavy tetracycline treatment regimen has increased sensitivity for the sunburns. The mechanism, I cannot tell you. I don't really know. Okay, my bet would be it somehow interferes with melatonin synthesis, maybe. So no new melatonin produced, and then you get sensitive to the UV light, especially the sun burn. Now, this table summarizes the mechanisms and shows you sort of an illustration of those mechanisms. So aminoglycosides here bind to the 30S subunit, okay, and they cause the tweaking of that 30S subunit. So proteins that are produced are faulty, and if those proteins, for instance, are inserted into the membrane, they will disrupt the membrane. They aren't used that much anymore. Well, streptomycin is used, kanamycin is used. A lot of those drugs are used in the research. Neomycin, kanamycin, gentamicin are used as the drugs to prevent bacterial growth in the cultures of the cells, the, what you might call it, mammalian cells. Okay, this is the broad spectrum antimicrobial. In fact, all of these drugs, except for lincosamides, have a very broad spectrum. Okay, and that was a huge advantage of those drugs. Okay, tetracyclines have probably the broadest spectrum for treatment. You can treat, name the disease, and it's probably treatable with tetracycline. From rickettsial diseases like Rocky Mountain spotted fever, chlamydial diseases, rickettsia and chlamydia are obligate intracellular parasites, to plague, to leukemia, gram-positive infections. Tetracyclines are truly broad-spectrum antibiotics. They prevent binding of tRNA to the ribosome, essentially blocking the synthesis of the protein. Now, chloramphenicol, lincosamides like clindamycin, and macrolides like erythromycin or azithromycin, in different fashions block the actual elongation, whether they blocking formation of the peptide bond during synthesis or translocation movement of the ribosome along the RNA. Does that make sense? So you can see that these antimicrobials all block either the initiation step that already started or elongation step. The quite unique drug called linezolid, okay, prevents formation of the entire complex between 50 and 30S. Does that make sense? So ribosome isn't even formed. In all these cases, there is a ribosome. Linezolid prevents ribosome from assembling. So it doesn't even let the synthesis start. Despite its effect, those antimicrobials in the therapeutic concentrations are microbistatic and not cidal, right? Except for aminoglycosides. Linezolid is often called the supplemental antibiotic. It is advised not to use it as the primary treatment. It is used when other treatment options for the infection have failed. Any idea why? Any reasons? What do you think? It's new. Why do you think it is suggested not to use it as a primary treatment? Although it's effective. Yes, so there's very low resistance to linezolid, right? So try this first. If it doesn't work, then use it. And that's why, so far, we're able to maintain the resistance to linezolid fairly low. Now, we're not going to go into membranes. I love those guys. They're like nuclear strikes. I want you to take